All right, good morning. My name is Jordan Fries. I'm the wound care nurse practitioner today, and this is Carl. Carl's come in today because he has a venous stasis ulcer on his leg here. Venous stasis ulcers we get due to the venous insufficiency within the veins. We end up with edema, and some fluid will leak out into the tissues, kind of cause a wound there. Usually those wounds are pretty weepy, they're very shallow, and they can get very large. And how we treat those wounds is with compression. So today we're gonna put an unna boot on for Carl, and we'll kind of go through the process of that. If we do have an open wound on the leg, we typically will apply a primary dressing first, so a Hydrofera Blue, Aquacel, Polymem, something to really absorb that drainage and help keep that wound clean. Unna boots can also be placed on patients with no wounds. We can use them just to kind of hydrate the skin and kind of squeeze some of that edema out of there and help in that process and prevent even more venous stasis ulcers from forming. So if this was a patient in clinic today, we'd put a primary dressing over that, and then we would put the unna boot on over top. So these are the supplies that you'll need. These are the unna boots that we have, and then the Coban wrap that goes over the top. And of course, before you put these on, you want to kind of just do a primary vascular assessment, make sure that there's good capillary refill, you're able to palpate pulses, things like that, because the unna boots do constrict just a little bit, so we want to make sure we're not causing any further complications by putting those on. We'll open our packaging here. So the unna boot comes out like this in a roll. It's just some gauze that's impregnated with zinc oxide. Looks like that. So we start at the base of the toes whenever we apply these unna boots, and I usually start on the top of the foot, and we just start wrapping around. When you get to the top, you want to pleat a little bit. That allows for some stretching. And you'll go around the foot. When we get to the ankle, we want to make sure that we kind of get the foot out there at 90 degrees. His foot's gonna drop just a little bit. So we'll go up, once we get the foot, we grab the ankle real quick, still keep pleating, and then we'll go down and we'll grab the heel. And then from there, we just keep going up. They don't have to be super pretty. I usually try to cover half of the previous wrap when I go up the leg. And you'll go till you get just a few finger lengths below the knee. Sometimes in the patients that have quite a lot of calf muscle or fat tissue back there, you may want to stop just a little bit before you get to that area so that the crease there doesn't cause any wound back behind the leg. So once you get to the top, you'll just go back down, use the whole unna boot roll. You can also cut it if you want to. If you have a patient, with shorter legs, or you feel like you're putting it on really thick, you can always just trim off the extra, but you just pleat all the way back down till you reach the bottom. So there you have on the unna boot part. At this point, I usually switch my gloves because the unna boot, the zinc on there will make the Coban not want to stick.
Now, what does the zinc oxide do?
So it'll help hydrate the skin. So in a lot of patients with venous insufficiency, they'll get that flaky, dry skin, and that just kind of helps to kind of soften those up and take those off of there. And then, so you have your Coban roll, and you'll just start down at the base of the toes. I usually leave a little bit of the unna boot out, just so the Coban doesn't irritate the skin. This you don't have to pleat, you just wrap around. So we'll wrap the foot. Grab that ankle, and then we'll grab the heel. And then again, I just try to cover half of the previous wrap again. This will provide your compression. You want it to be a little snug, of course, not causing the patient any discomfort, but the point is to squeeze the leg a little bit, so we don't want them super loose. And once we get to the top, I usually just tear it or cut it right there. I don't wrap back down. And then I just press there. You can add tape if you want. If we have patients that the wound is really draining, none of this absorbs anything. So if your primary dressing isn't going to hold all that, I will add like a roll of Curlex or gauze between these two layers. So unna boot, then Curlex, and then I put the Coban over the top. We typically change these Mondays, Wednesdays, and Fridays. If drainage is super heavy, once drainage starts to slow, sometimes I'll back the patients off to twice a week. And then if the wound heals and we're really just doing this to help with compression until we're finding some kind of alternate therapy to support the edema, we can even leave it on for up to a week. So it really just depends on how much the wound is draining. Do they have a wound in place? Because you don't necessarily have to have a wound to put these on, but this is usually one of the basic treatments for venous stasis insufficiency when they have a venous stasis ulcer. So,
Thank you.